thank you very much for being here for this last session. And this is a very interesting session on the year in review of 2022. And we are going to have two speakers for this session. Paula?
First of all, Dr. Danieli Andreani, who is professor, head of the Antiphospholipid syndrome and laboratory, Facultad de Medicina, doctor in medicine of the University of San Pablo.
And the other speaker is going to be Dr. Jason Knight. He's working at the Barbara Boker Center of Women and Rheumatic Diseases in the Hospital of Special Surgery in Weill Cornell Medicine in New York, USA. He's going to start with the first session, and then we are going to have Danieli for the second clinical part. So welcome, Jason.
Hi, everyone. My name is Jason Knight. I'm a rheumatologist at University of Michigan in the United States. Thanks so much for the organizers inviting me to speak on this very exciting, albeit daunting topic. These are my disclosures. My criteria were pretty arbitrary. These were papers that were interesting to me and I hope will be interesting to you. I look for papers published after the summer of 2019. As you will see, we're only going to hit on each paper very briefly. So the goal is to inspire you to go back and look at them in more detail. And we're not going to be talking about COVID-19 today. Here are the different categories that we will hit. Some papers about the beta-2 protein, some new ways to think about what an antiphospholipid antibody means, some papers that used big data, some that focused on different types of cells, and then we'll think about what's new in kind of preclinical studies. So many great papers that I had to cut out or unfortunately missed, and I apologize to those authors. Feel free to email me as much as you want after this to discuss. I love this topic. So what's new with beta-2? So here's a paper you likely have seen. Beta-2 knockout mice have been studied in a lot of contexts, but not as much as you might expect in the setting of thrombosis. And so what the authors found is either in arterioles or venules, we got accelerated thrombosis in beta-2 knockout mice. One mechanism they found was increased neutrophil interaction with the endothelium, including increased elastase release, as we can see in structures such as nets. So a great read. I really encourage you to go look at the discussion of this paper. Lots of hypotheses about neutralization of nets or phospholipids, perhaps impact on complement. Very exciting work, and surely we'll see more on this front. So here, let's talk about beta-2 structure. And so this is a paper that kind of challenges some dogmas. Dogma being that when beta-2 is in solution, it is in a modified form in which domain 1 is not accessible for antibody binding, and it is only with engaging phospholipids that that access is revealed. So this is the first crystallography of beta-2 that's happened since the 1990s. And again, beta-2 ended up in a J shape, as had been seen before. The caveat can be that high salt concentrations are required, and so beta-2 was looked at in solution with some different approaches. Here is this FRET analysis. When strategically placed fluorophores were used to understand the distance between different areas of the beta-2 protein, and those distances were very consistent with this J shape as was found in the crystal structure. So other methods of confirmation included some studies looking for interaction between domain 1 antibodies and the beta-2 protein in solution, and those were in fact successful. So definitely worth taking a look at this paper. Here is a follow-up study by the same group where the focus was on disulfide bonds. So they found that eliminating this disulfide bond group near domain 1 decrease the efficiency of APL binding. So that's cool and kind of expected. Similarly, if we disrupt things near the C terminus, we eliminate efficient phospholipid binding. Now, I pulled out just one experiment here. So this is binding the phospholipids and asking how much that can be accentuated by the presence of an anti-domain 1 specific APL. And so I thought cool to see that this mutation or this change, you could say, in the N-terminus is sufficient to not only disrupt the antiphospholipid binding, but disrupt binding to phospholipids in the setting of the APL. So reinforcing that special relationship between APL and beta-2 protein and phospholipid. Here was a paper questioning pathways to complement activation. The authors hypothesized that because beta-2 is glycosylated, it might activate complement through the mannose-binding lectin pathway. Interestingly, they found that beta-2 does associate with MBL, but it ends up being independent of glycosylation, so surprising finding. They found the association was through domains 2 and domains 4. And then here, trying to look at the intersection of complement and coagulation, found that prothrombin activation on top of HUVEX was accentuated in the presence of beta-2 plus MBL. And then finally in this section, just a quick look at beta-2 in the brain. This is a model of stroke caused by carotid artery occlusion. Within 48 hours of the occlusion event, we can find more beta-2 being churned out by the liver, and that ends up in the plasma. Now at baseline, we do not find beta-2 in the brain, but soon after the event and only increasing over time, beta-2 becomes detectable in both brain parenchyma and brain endothelium. I think potential interesting implications for stroke patients who also have anti-beta-2 antibodies. So cool, really exciting to see beta-2 having an effect on thrombosis in microvessels. We look forward to seeing what is shown in other vascular beds. Really cool work. I think provocative evidence that this J shape exists, and the paper argues actually predominates in solution. You know, why we don't see immune complexes so much in APS is, I think, an interesting question for the future. And then if beta-2 can activate complement through this MBL pathway, you know, what are the implications for APS? So going forward, let's get the structure people together and let's hash this all out. The rest of us are really exciting to continue to see what you come up with. So what about antiphospholipid antibody concepts? We put it in quotes because we know antibodies associated with APS can mean different things. So this is not the newest concept, but being studied in a new context. So beta-2 HLA-DR complex antibodies in the setting of obstetric APS. So you may not have, and I'm sure you did not actually learn about this pathway in your immunology classes. We think of HLA class 2 in a certain context, but it turns out a non-canonical role is presentation of misfolded proteins on cell surfaces. There is precedent outside of APS for this contributing to autoimmunity, including rheumatoid factor production in RA and anti-MPO antibodies in ANCA vasculitis. And so prior work in APS had suggested that when beta-2 is presented in this format, it reveals some unique epitopes that you might not see in other beta-2 contexts. So here is a cohort of 227 individuals who have had recurrent pregnancy loss, and a subset of them have antibodies to this complex, but not other types of APS-associated antibodies. If you like APS genetics, then this is just a little note that is in the paper that HLA-DR4 seems to be especially associated with presentation, or at least antibody development to this complex. So here was a splashy paper that I'm sure you'll hear more about at this meeting. There's a lot going on in this paper. We can only touch it very superficially. The authors looked at this association between a phospholipid called LBPA and EPCR, which is the protein C receptor on the surface of different types of cells. On monocytes, they found that engagement of that led to things such as tissue factor activation, and through endosomes on dendritic cells drove TLR7 expression. So I think an important note is that to find these patients, you need to develop an ELISA that's different than what we often focus on in the clinic. So we need beta-2 independent antiphospholipid assays. And so the authors use a kind of a homemade ELISA that has limiting amounts of beta-2, and it will pick up phospholipid-specific antibodies that don't need a cofactor. So again, too much data for me to cover, but this is just one of the approaches they use. So here is a mutated form of the protein C receptor, and that mutated form is not able to exchange phosphatidylcholine, which is an original part of the protein C complex, with this novel phospholipid called LBPA. And so when that happens, you really suppress the ability of these phospholipid specific cofactor independent APL to activate cells. So pretty cool. Also can't wait to see where this leads, including in terms of maybe novel ELISAs or other immunoassays for the clinic. Let's talk about carbamylation. So this is a post-translational modification that occurs in the setting of inflammation, especially neutrophilic inflammation, as it's driven by myeloperoxidase. So the authors found anti-carbamylated beta-2 antibodies in patients with traditional APS, but also in some patients with the so-called seronegative APS that do not have traditional antibodies, but seem to have the clinical phenotype. So that's always exciting. And then mechanistically, they found that carbamylated beta-2 had immunostimulatory properties, including dendritic cells, which might contribute to break-in tolerance. So anti-net antibodies, this is a concept that my group led by Ray Zhu has been working on. And so he uses a ELISA assay that he developed in which nets are generated, partially degraded, and coated into plates. When he does that, he found that patients with primary APS, even more so than patients with lupus, have anti-net IgG and anti-net IgM. Interestingly, there seems to be a negative correlation with complement levels. Anti-beta-2, we don't think of as an immune complex former, but maybe these antibodies are better at doing that, and that's work that we continue to pursue. And here is just some pretty immunofluorescence microscopy showing that high anti-net plasma is very good at decorating IgG onto preformed nets. The last paper of this section is just to put out the idea that hopefully we'll see more studying of different antibodies together in the same paper. So the authors used a cohort or two cohorts. One had high anti-beta-2 activity, low anti-PSPT, and the other was vice versa. And when they put these IgGs into functional assays, they showed that both worked pretty similarly. So in terms of kind of where to go, I think time to circle back and pay more attention to true antiphospholipid antibodies, these cofactor independent ones, and how they may synergize and communicate with anti-beta-2 antibodies. Everyone has these unique assays. Can we get better at working together and testing them side by side in well-characterized cohorts? And I guess a philosophical question, if we ever completely understand autoantigenome, is that finally going to reveal this heterogeneity that we see in the clinic, or are there other things that we need to be looking at? And so another philosophical question, will we ever understand this well enough that we can move on from lupus anticoagulant assay? All the information that very useful assay gives us now can be replaced by immunoassays. We'll see. Okay, big data. Let's hit on these papers quickly. So here was a paper that looked at the transcriptome of APS monocytes, 40 APS patients. It was a cohort that was enriched for patients with kind of preclinical atherosclerotic disease, which let them do some interesting analyses. If you do the simplest analysis, healthy versus APS, you see these inflammatory pathways upregulated. If we drill down into the 40 APS patients, you see that they cluster into 3 groups. And it's this more inflammatory cluster, albeit a relatively small number of patients that seem to have the highest cardiovascular risk. So here is a paper that looked at APS in parallel to other rheumatic diseases. And so the authors used whole blood transcriptomes, and they tried to force patients into one of 3 groups, either inflammatory or lymphoid or interferon, and that was independent of the disease. These were the different diseases they looked at. Primary APS was a smaller group shown there in the light blue. Unfortunately for us, most of the APS patients hit the undefined group. Not a lot of details in the paper to understand exactly who these APS patients were. Hopefully we see this type of analysis in larger cohorts in the future. Here, another cool paper looking at complement, and it has one big data element. The core part of the paper, though, is focused on this modified HAM test. So using cells that are extra sensitive to complement activation and complement-induced death, and understanding what happens to them when exposed to patient serum, modified from the HAM test where the cells from the patient have the problem, and that's what we're probing. So modified HAM test positive was more often found in patients with history of CAPS and in triple positive patients, so that's always notable. And then here is the big data sub-analysis. They looked at a panel of 15 genes looking for known complement variants, albeit rare ones, and 60% of the CAPS patients, lower percentage of other patients had these variants, suggesting it may contribute to the fact that they developed CAPS. So what about platelets? So here's a study that looked at platelet proteome. They had a cohort of lupus anticoagulant positive patients. Some had thrombotic events in their history, some did not. They used 2D gels to identify the different platelet proteins and which looked like they were differentially regulated. They made a list of 25 different proteins that were differentially regulated in APS versus control. I only picked out a few here that they kind of emphasized in the paper. One is protein disulfide isomerases, which we know are pro-thrombotic and which were upregulated in the APS platelets. The other was this serine protease inhibitor. Serine protease is especially found in cells like neutrophils, and so this protein has anti-neutrophil properties. The authors speculated that this might contribute to increased netosis, and they did find a correlation. Low leukocyte elastase inhibitor expression was associated with more nets in the blood of the patients. And then DNA methylation, always a good topic when we're thinking about big data. So this study was not genome-wide, but I think shows us what can be possible. The authors rightly point out that this is a big deal in the lupus field where methylation has been much studied. And so here they just looked at 2 genes known to be potentially regulated by methylation. So they found decreased IL-8 promoter methylation, which should predict more expression. And then they found the opposite, but again, when there's methylation in the first intron of the tissue factor gene, that should associate with more expression, and that's what they found in the APS patients. Now, when they look not at epigenetics, but at gene expression in an in vitro system, they found IL-8 and F3, which codes for tissue factor, were both upregulated. And I think the reason to think this could go bigger is that they also find differences in various epigenetic regulatory factors, suggesting other parts of the genome might be affected. So this is just something I've been thinking about. Monocytes we'd like to study in the lab because they're relatively easier than some of the other cell types. I think it's encouraging the data suggesting that these can help us differentiate our patients because it would make our lives easier. Let's see what the future holds. This is an opportunity, I think, to break into the field. There's a lot of modern approaches that really haven't been applied to APS yet. So for you young researchers. And then going forward, I think there's even some relatively simple things that haven't been done, and hopefully we'll see these 3 years down the road. Okay, this cell category is a little bit of a hodgepodge. Here is a cool paper about a paradoxical role of tissue factor pathway inhibitor. So the authors found this, and so paradoxical because you normally think of this as an anti-coagulation, anti-thrombotic factor, but here the roles seem to be opposite, at least in the setting of APL. And so the authors were studying tissue factor pathway inhibitor in complex with other proteins on monocyte cell surfaces. Here they have stimulated the monocytes with a cofactor independent cardiolipin reactive antibody. When they do that, they see factor 7 is internalized, a tissue factor pathway inhibitor now lonelier on the cell surface, and then factor 10A disappearing altogether. So they make the suggestion that this release of factor 10A out into the world is going to drive more thrombin activation. And then they have some cool data in mouse models showing that myeloid-specific TFPI deletion is actually protective in an APS mouse model. Cool. So here is a brief report that caught my eye because it highlights nets, which is a topic I like. Nets are prothrombotic in APS, and certainly outside of the APS field, there's very solid evidence of that. Another pathway that has been much studied in APS is activated protein C resistance. The authors try to bring the two together. So especially if they look at higher risk patients here, anti-domain 1 positive versus negative, they see both increased activated protein C resistance and also nets, and then see a positive correlation between the two. How those are communicating, if at all, I think warrants further mechanistic research. What about the microbiome? So here was an interesting paper that just met the cutoff, published in the summer of 2019. The authors went looking for potential cross-reactivity with They looked for proteins expressed by bacteria that might have both the B cell and T cell epitopes that we see in beta 2. And they found one candidate in the DNA methyltransferase of this R intestinalis. So they show that these anti-R intestinalis antibodies correlate with anti-beta 2. Interestingly, APS patients have more intestinal inflammation, which could contribute to breakdown intolerance, more leaky gut. And then in APS mouse models, they found that colonizing mice with R intestinalis, if the mouse was predisposed to anti-beta 2 activity or anti-beta 2 antibody development, such antibodies did develop. And then finally, a word about exosomes. So this was a little paper, but I think it's an interesting concept. So they looked during pregnancy at 6 APS patients versus 6 non-APS pregnant individuals. A number of proteins were up in the APS exosomes, including, interestingly, beta-2 glycoprotein 1. These patients did not have the strongest APL profiles, and so one will be interested to see this repeated in a new cohort in the future. But the interesting thing is the mechanistic studies. So they did give these APS exosomes to mice, and when they did so, there was more fetal loss, and they phenocopied that with an in vitro system where they overexpressed beta-2 in cell lines and made exosomes there. And those exosomes also seem to drive more fetal loss. So food for thought. Finally, I wedged in one more complement paper, which I think kind of confirms what we showed before. So here looking at CAPS patients, either before or after their acute episode, just 7 patients, but a difference in smoldering complement activation. And so, raises this question, can we identify patients for preemptive treatment versus only thinking about drugs like this in the setting of an acute flare? And so that's what I'm saying here. These drugs are becoming available. Are we going to find a way to use them in the clinic? Will we ever figure out the right cells to target? Researchers coming at APS from a lot of different cell perspectives. Maybe that's not the right way to think. We should be thinking about common inflammatory pathways. And can we eventually get to interventional microbiome research, which I think will be really appealing to patients? Going forward, can we work together even better? And then finally, what's new in the preclinic? We'll hit this quickly. So I probably gave not enough pregnancy studies today, which maybe just speaks to my comfort level, but here is one that I will give you. And so, the authors remind us that ApoE-R2 has been shown to be kind of a co-receptor along with beta-2 on the surface of trophoblasts. And as the downstream pathways have been dissected, one key player that has emerged is PP2A, and key because there are inhibitory approaches out there, including this agent that was first isolated from this type of so-called blister beetle. And so in the experiments, the authors kind of recreate previous work that ApoE-R2 knockout is protective. When they do in vitro studies, they find PP2A upregulated, and then PP2A inhibition protective in the mouse. Heparinase, another interesting topic. So here, just in vitro studies, no mouse studies. Outside of the APS field, heparinase and tissue factor expression seem to communicate. So the authors screened several heparinase inhibitors for cell toxicity, and they settled on one that had low cell toxicity, and then did experiments with APL. So here, looking at tissue factor upregulation in endothelial cells or platelets, we see it go up with anti-beta-2 antibodies, but come down in the setting of heparinase. Await preclinical mouse models, I think. So we've seen pegylated beta-2 before, but just a quick reminder with this short little paper. So here the authors did weekly immunization with human beta-2 to create a pro-thrombotic phenotype. And indeed, all of the mice, regardless of treatment group, did get anti-beta-2 antibodies, or all the mice that were expecting, the ones that weren't controls. And then here are thrombosis data. So accelerated thrombosis in the positive control, decreased with a non-pegylated version of domain 1, so kind of proof of principle, but then showing that pegylation, it could be that pegylation would disrupt that protective effect, but it does not. So we await studies like this, but in longer term models, I think. The fibrotide, so this is some work that we did. It was the idea of Doric Erkin based on this case report that he contributed to about catastrophic APS. We've all referenced this case report in our review articles, although I don't know how many patients have actually received the fibrotide in the clinic. This is kind of a strange drug. It's a proprietary blend of oligonucleotides. Its association with bleeding is certainly not like heparin. It does not have the anticoagulant properties of a heparin, but it does seem to have antithrombotic properties. Here's a paper that we wrote in A&R that you can check out. I think it's in the journal itself this month, showing a role for defibrotide in inhibiting net release. Here's a paper you may not have seen, though, that I wanted to highlight a few data from. So here asking what happens if the nets are already out of the barn, if you will. If nets have formed, might defibrotide neutralize them? And so here's an in vitro study showing activation of endothelial cells with nets, pushing that activation down with defibrotide. And then if we look at histones in particular, histones are the most abundant protein in nets. They're very inflammatory when outside the cell. We show that defibrotide binds tightly with histones, not surprising since it's an oligonucleotide. It blocks histone-mediated cell activation very strongly, completely suppresses it, and then also has some positive effects in histone-accelerated mouse models. And then finally, for fun, a word about ginger. This is one other study that we published recently. So we got interested in this because there are some old data that gingerols, which are the bioactive component of ginger root, can function as phosphodiesterase inhibitors, which should give anti-inflammatory properties. We've shown in other settings that boosting cyclic AMP is a good way to dial back inflammation, including in neutrophils, including net release. And so indeed, we replicated some old data that gingerols behave similarly to synthetic phosphodiesterase inhibitors. Gingerols can suppress netosis in vitro, and then even in mouse models of APS, they can be suppressed by 6-gingerol. So what's new in the preclinic? We see more of these intracellular signaling modulators coming to our clinics, at least if you're a rheumatologist. Can we understand APS signaling pathways well enough to understand if there's a subset of our patients that would benefit? Will any of these suppressive strategies ever be effective enough to replace anticoagulants? I mean, short of the holy grail that is a cure, I think this is second holy grail. Can we find smarter treatments that eliminate blood thinners? And then going forward, I think, as a field, our ability to roll out clinical trial after clinical trial in hundreds of patients may be limited, but I think there's an opportunity to, try repurposing drugs, look at mechanistic endpoints, smartly pick the very best drugs for larger trials. So thanks again for all the time you spent with me. Sorry we hit so many papers. I hope you'll go back and look at some of them. And again, I apologize for the papers that I either missed or ran out of time. This is the third time I've recorded this talk, and it's going to be the last one. So thanks again. Please ask me questions now or by email or by Twitter.
We are going to keep the questions from the final of next talks, who is going to be performed by Professor Danieli Andrade.
So first, I want to thank the opportunity for giving this very challenging talk. I also want to thank people who are here until the very last talk. And I really need to do this very special, thank for Guillermo and for Paula for being so nice, for their hospitality. It was beyond whatever we expected. And I really feel sorry for people who didn't come to Argentina to feel their love. So I'm going to start with the 3-year in Reveal clinical. Oh, so I have to do it, I forgot. So the rationale used for selection were clinical APS, APL papers interesting for the ICAPA attendees from higher impact fact journals, case reports that suggested an important insight in APS. I excluded Reveal papers, so I came out with 97 papers, and in the end, due to timing, I had to select less than 10 papers. So I'm sorry that I could not cite all papers I wanted to. So the first paper that I consider that is very important is to remind everybody about the development of the new international antiphospholipid syndrome classification criteria, the phase 1 and 2 report. So actually this was an international initiative supported by the ACR, and Euler to develop new rigorous classification criteria for research purposes. And this was done under the evidence and consensus-based approach to identify and develop hierarchical organization of criteria with domains. So I'll go very quick. They had the first time there was the phase 1 item generation, so they really emailed researchers about open-ended questions. Then there was an expansion to incorporate negative weighted responses, and then was the second phase. There was actually the item reduction, where those items with low specificity, with a Likert score lower than 1, were eliminated, and in part B, those items that had a low specificity with a Likert score lower than 2 were eliminated. So they came up to 152 candidate criteria that were expanded to 261, and then after reduction, they came out with 64 potential candidates, in total 10 clinical and laboratory domains, and in the end, 27 candidate criteria that were hierarchically organized into 6 domains: laboratory, macrovascular, microvascular, obstetric, cardiac, and hematologic for APS classification. So here we can see that some items, they were eliminated because they were repeated, like pulmonary hypertension due to thromboembolism, heart failure due to ischemia, from the dermatological livido reticularis, atrophy blanche de Milian, pyoderma gangrenoso, like ulcers, anetoderma. From hematologic, microangiopathic hemolytic anemia, positive comb tests with no hemolytic anemia, and many of the neurologic and non-criteria manifestations. Pay attention to this: seizure, epilepsy, multiple sclerosis like migraine, chorea, cerebral white matter lesions, cognitive dysfunction, longitudinal transverse myelitis, and multi-infarct dementia. From the obstetric domain, chorea, gravidarian, pregnancy-induced hypertension, and from the laboratory, the non-criteria APL. Of course, we consider most of them, or especially some of them, very important, but we still need other research to include this non-criteria APLs: anti-domain 1, anti-PSPT, the IgA, and anti-prothrombin antibodies. So in the end, we had the 6 domains, and you actually need to remember that some important items were included, like livedo racemosa, livedoid vasculopathy, nephropathy, non-infectious valve disease, and also low platelets. And then in the third phase, they had the collection of real-world international APS cases for weighting and threshold determination, and for this, they used the multi-criteria decision analysis methodology and 1000-mind software. So the objective was to define more on a specific criteria than a sensitive criteria, to define or to include the non-criteria manifestations. Non-criteria APL need further studies, and one of the objectives is to develop the weighted scoring system to improve criteria performance. So the second paper I selected is about the effect of hydroxychloroquine on thrombosis prevention and antiphospholipid antibody levels in primary APS. This was a pilot, open-label, randomized prospective study. So we can see that the primary objective was to define safety and efficacy of hydroxychloroquine. So they ended up with 25 patients in standard care versus 25 patients in standard care plus hydroxychloroquine. And they also included 15 asymptomatic APL carriers so that they could compare the APL levels. These patients, they were followed for a 3-year period, and they were considered ideally anticoagulated if their TTR, time to therapeutic range, was higher than 80. And actually what they observed is that 6 thrombotic events, and for those people who were randomized to standard care, and 1 thrombotic event for the group that was randomized to hydroxychloroquine. And this patient that had the thrombotic event, he was not taken hydroxychloroquine for the preceding 4 months. So they did the analysis doing the Kaplan-Meier curve of thrombosis-free survival, comparing PEPS patients with hydroxychloroquine versus standard care alone, and they actually observed an 80% reduction in incidence of thrombosis. But when they did the multivariate Cox regression to evaluate the effect of hydroxychloroquine on thrombotic risk among the other risk factors, you can observe that hydroxychloroquine did not behave independently. The patients, they were triple positive since baseline. And they also looked for the longitudinal antiphospholipid antibody titers, and you can observe that comparing the both arms, they observed a reduction for anti-beta-2 GP1 IgG, IgM, a trend for anticardiolipin IgG, and actually nothing for IgM. But we definitely need further prospective multicentric double-blind studies to confirm these findings, and we have the ongoing hibiscus trial. So the third paper is the comparison of apixaban with warfarin to prevent thrombosis in thrombotic APS patients. This was a randomized trial. So they did a multi-center prospective randomized open-label blinded event endpoint study. So to have a power of 80%, observing 1% of difference among each group, they needed something like 4,000 patients, and this was just impossible for a rare disease like APS. So they came out with this 200 patients. That was a kind of a pilot study. So apixaban, 2.5 milligrams 2 times a day was given for the patient, but actually due to arterial events, they had to increase the dose to 5 milligrams per day, 2 times. Per day. And after the inclusion of the 20th patient, they decided to include a prior MRI for inclusion. And after the 30th inclusion of the patient, arterial events, preview arterial events were excluded due to safety. So the primary outcome of this study was thrombosis and vascular death. The safety outcome to observe major and clinically relevant bleeding. And actually, they had to stop the study. The study suffered an early termination in patient 48. These patients, they were followed for 12 months. And when they compared 23 patients in the apixaban group versus 25 patients in the warfarin group, they observed 6 strokes in the apixaban, no stroke in the warfarin group, but 1 bleeding. These patients, they were kind of similar regarding their other clinical the clinics. So, so they decided to evaluate the results for this paper, doing a combined primary efficacy and safety outcome. And they did the Kaplan-Meier cumulative event rate for thrombosis, and they observed 318 events for the apixaban group versus 40 events per 1,000 patients for the warfarin group. This is very interesting. So when they assessed patient satisfaction with anticoagulation, actually, this is expected, right? People were much happier with apixaban than taking warfarin. And they also checked all patients who suffered events. And for the 6 patients who suffered a stroke and 1 patient who actually had bleed, and this patient, we had 2 patients from each group, like 2 definite APS, 2 likely. There were patients with radiological thrombus confirmation plus 1 lab result, and 2 patients from the historical group. There was history of thrombosis plus history of lab result. So apixaban may not be routinely substituted by warfarin for APS patients. Those should be given with caution for APS patients, and at this point avoided in lupus anticoagulant, triple positive, and arterial patients. So this is the EULAR recommendations for cardiovascular risk management in rheumatic diseases, including SLE and APS. So this was an EULAR initiative to develop a multidisciplinary task force for cardiovascular risk prediction and management based on systematic literature review and expert opinion. So when we look for the level of evidence of the papers that they searched and the grade of recommendation, we are all aware of the level of evidence that our APS papers comes from. So, and here we can see that it seems that the level of agreement between the experts was very high for these conclusions here, so that clinicians should be aware that these patients have increased cardiovascular risk, that rheumatologists are impossible and should collaborate with other physicians to take care of these people, and that they should have a strict control of cardiovascular risk factors, smoke, cessation, management of blood pressure, lipid, and diabetes, and that they also should be regularly followed up. And we also need to improve our patient education and counseling. Not easy, too many things to do in a single appointment. So, and here I'm presenting the results for SLE and APS. So, the traditional cardiovascular risk factors and disease-related risk factors is recommended to guide risk factor modification with a very high level of agreement. In patients with SLE and APS, lipid treatment should follow recommendations used for the general population. And that is an important point, that in asymptomatic APL carriers not fulfilling our classification criteria with a high-risk APL profile, with or without traditional risk factors, prophylactic treatment with low-dose aspirin is recommended, with a level of evidence 2A. In patients with SLE and no history of thrombosis or pregnancy complications, but with high-risk APL profile, prophylactic treatment is recommended. And for those with low-risk APL profile, prophylactic treatment and low-dose aspirin may be considered. Sometimes this is a matter of a lot of controversy. And we know that the research agendas and whatever they proposed is that we need to understand a little bit better the biomarkers that these patients have and how this can interfere with cardiovascular risk assessment, that we also need to understand how the drugs that we give them can modify their risk factors, that we need large educational campaigns to better orientate our patients. I couldn't skip this topic here, right? So the paper I chose to talk about COVID and antiphospholipid antibodies was the position and statement and management of the APS section. So we are all aware of the common mechanisms that are behind COVID and APS, endothelial activation, complement activation, netosis. We know that patients who are in the intensive care unit, and if they have COVID, they have a much higher risk of thrombosis. In those papers that report COVID and APS, low-pulse anticoagulant was positive up to 50% of patients in the intensive care unit, but high APL titers were rarely reported. In many of these papers, there was only one time point measured, and it seems that there are differences regarding the beta-2 domain reactivity when you are comparing patients with infectious disease versus thrombotic disease. And it also seems that these people, they have more other non-criteria APLs. So is antiphospholipid antibodies in COVID associated with increased risk of thrombosis? So the clinical significance of APL in COVID is still undefined, but from Jason's group, it seems that COVID-associated IgG fractions isolated from patients-induced thrombosis in mouse models. So, but we know that there are several case reports of APS SLE worsening during COVID. So what about the management of APL positive patients with or without APS? So new APL should be retested after 12 weeks. Definitely this is very important. And also hospitalized patients, they should receive prophylactic dose of anticoagulation with low molecular weight heparin. So just one question. I see time's up, but because I had half an hour, right? Yeah. So what about the general management recommendations for persistently APL positive patients with no COVID infection? So the most important thing here is to distinguish if you have an inpatient or if it's an outpatient, this is definitely very important. So if you have no history of thrombosis and or not on long-term anticoagulation, if it's an inpatient, you should start at least prophylactic dose anticoagulation with low molecular weight heparin or unfractionated heparin. If it's an outpatient, you should consider prophylactic dose anticoagulation depending on the additional risk factors. If the patient does have a history of thrombosis on long-term anticoagulation, you should definitely switch to therapeutic low-dose heparin if it's an inpatient. And if it's an outpatient, you should continue anticoagulation with regular INR monitoring. And what about for pregnant who are not on anticoagulation? If it's an inpatient, start at least prophylactic dose anticoagulation. And if it's an outpatient, consider prophylactic dose anticoagulation given their increased risk of thrombosis. And pregnant people on anticoagulation with or without low-dose aspirin, if it's an inpatient, you should continue anticoagulation, at least prophylactic dose for patients, and therapeutic dose for patients who are on therapeutic doses. And for the outpatients, you should continue anticoagulation based on the original dosing strategies. So vaccination and COVID, we know that APL-positive patients with or without APS, they are recommended to receive a COVID-19 vaccine. We are all aware of rare cases of thrombosis with thrombocytopenia following two adenovirals, Astra and Johnson. These people developed a disease close to autoimmune heparin-induced thrombocytopenia with antibodies, anti-PF4-like antibodies. So do not give heparin for these people. Avoid platelet transfusion, and IVIG is very welcome. So for patients on rituximab, you should receive the vaccine or recommend the vaccine 4 weeks prior rituximab and delay it 2 to 4 weeks after vaccination. So I'm almost in the end. And this is I consider this a very important topic, that is the 2020 American College Rheumatology Guideline for the Management of Reproductive Health in Rheumatic and Musculoskeletal Diseases. So the objective here was to develop an evidence-based guideline on contraception, assisted reproductive technology, hormonal replacement therapy, and pregnancy. They did a systematic review, and ACR, the ACR guideline provided 12 ungraded good practice statements and 131 graded recommendations for reproductive health in rheumatic disease. So the first thing, we should discuss contraception with our patients. And it's very important, so I need to go back. Yeah, so it's very important to observe if the patient is APL positive or APL negative. And for this guideline here, you should consider if it's green, it's strongly recommended. If it's red, it's strongly recommended against. And if it's in the middle, light green, conditionally recommended, and salmon, conditionally recommended against. So the first thing, you should access APL status. If it's positive, avoid combined estrogen-progesterone contraceptives. If it's negative, you should consider, does the patient have lupus or does not have lupus? If the patient doesn't have lupus, you can give them almost everything you want. But if the patient does have lupus, you need to assess disease activity, if it's low disease activity or if it's moderate to high disease activity. Always avoid estrogen patch. We still don't have data for this. And if the patient does have moderate to high disease activity, you should give other methods over combined estrogen-progesterone contraceptives. Regarding assisted reproductive technology, you should determine disease activity for rheumatic disease. So if the patient does have moderate or severe disease activity, refer it. But if the patient is in remission or has a stable low-level disease activity, you should continue this. You should adjust the pregnancy drugs. You should not leave these patients on cyclophosphamide for obvious reason. Avoid prophylactic use of prednisone unless required to control disease. And then you should access APS status. If the patient is negative for APL, go ahead. If the patient is positive for APL but does not have APS, you can proceed, but you should give prophylactic low molecular weight heparin, and this is the same for OB patients. And for thrombotic patients, you should give them therapeutic low molecular weight heparin. So regarding pregnancy, I'm not discussing lupus, okay? So you should consider first to assess disease activity. If the patient does have a low disease activity, go ahead, adjust the treatment. If the patient does have a high disease activity, you should recommend the patient not to get pregnant. And about the APL tests, if the patient doesn't have APS, you could give the patient low-dose aspirin to prevent preeclampsia, and they kind of recommend against prophylactic heparin or hydroxychloroquine. And regarding OB APS, you should treat them with low-dose aspirin plus prophylactic heparin. You can give them hydroxychloroquine, but they are against what I've said before. And for thrombotic, low-dose aspirin plus therapeutic heparin. So my last one in this topic is about the hormonal replacement therapy. So for hormonal replacement therapy, you should assess APL status and APS. If the patient does have APS and is anticoagulated, you should avoid the kind of recommend against the hormonal replacement therapy. If the patient has APS and is not anticoagulation, you definitely avoid hormonal replacement therapy, even if the patient at that time is APL negative. And if the patient is APL positive but does not have APS, you assess the current APL titers. If the titer is positive, avoid hormonal replacement therapy for obvious reasons. And if the APL titer is negative, you give it if it needed. And if the APL is negative and the patient doesn't have lupus, okay, you go for it. If the patient have lupus, you do hormonal replacement therapy if needed. So the guideline is intended to provide guidance for patterns and practice and not to dictate care of a particular patient. There is not sufficient evidence for many clinical situations discussed in the guideline, but this is the best knowledge available we have at the moment that have been used to build up this recommendation. So I'm almost finishing. I consider this very interesting. So this is an antiphospholipid syndrome-induced ischemic stroke following pembrolizumab. This is a case report. And the reason why I chose this to be presented here is because we know that our oncologists, each time they are using more the checkpoint inhibitors, and pembrolizumab is a checkpoint inhibitor. So what they do is that they try to stimulate the immune system against the tumor, but then they overstimulate the immune system, and then you have many other autoimmune diseases. So this is a case of a patient with non-small cell lung cancer that was treated with pembrolizumab, and you can see from B to D, the patient had a complete resolution after 1 dose of pembrolizumab. But 6 days after the second dose of pembro, the patient developed dysarthria and left hemiparesis with normal blood pressure. You can see that definitely the patient had an ischemic stroke because of a thrombosis in the right middle cerebral artery. But when the patient was treated with intravenous tissue plasminogen activator and suffered a mechanical thrombectomy, actually there was a revascularization, and you can also check the patient evolution in the MRI. They did a very complete neurovascular workup. The patient actually had high titers for anti-beta-2 and also 2 other autoimmune manifestations. This is quite common. So the patient had psoriasis and transaminitis. So they did a liver biopsy. They could not find any sign of thrombosis. The patient was treated with intravenous prednisolone, 2 milligrams per kg, and with low molecular weight heparin, 1 milligram per kg 2 times a day. And the follow-up after 3 months, the patient had full neural recovery. The titers for anti-beta-2 GP1, they went low. And so at this point, they resumed aspirin. They stopped the low molecular heparin. And 1 year after the event, the APLs were undetectable. So this comes together with 4 other cases that happened in patients with melanoma that were treated also with checkpoint inhibitors. And you can see that patient 4 even had catastrophic APS. And the other 3 patients, they had distal ischemia, they were APL positive. So I think that we should all be aware, because this can come to our private or public hospitals, and we should be aware of that and work a little bit closer with the oncologists. So checkpoint inhibitors are a revolutionary treatment for aggressive cancer. Autoimmune manifestations have been recognized as a potential side effect of therapy, and maybe we might learn something from our disease pathogenesis, the autoimmune disease pathogenesis, looking this backwards, right? And my last paper is about the variability in the presence of clinical manifestations associated with APS in HLA DR4, DR7, and DK8 positive families. So see, this is very interesting when we evaluate this heredogram. You see the mother, there was patient 3 and had APS, and she shared DR4, and she shared also DK8 with the twin sisters, patient 1 and 2. Patient 1 had APS, patient 2 had APL, and they were haploidentical. And what is proposed here is that probably there are some epigenetic important extra factors that might help these patients to evolve or not into APL to APS. So the patient 2, for example, when she got pregnant, she was treated with low molecular weight heparin, and probably we might be missing the additional extra risk factors that these 2 haploidentical twins had a different disease phenotype. And this has been previously described in 2 other families that were HLA DR4 positive, also in monozygotic twins, and their clinical phenotype was thrombocytopenia, APL, and APS. So I'm happy to say that I come from this very big hospital with very complex cases. I'm very proud to help people in the public system back in Brazil, very, very poor people, and with very severe and complex disease, and I'm very thankful for them as much as I learn from them. And this is where I spend most of my time in the University of São Paulo. Thank you so much.
Thank you, Danieli, for your kind and excellent talk. I think we have Jason Knight leave. Hello, Jason.
Hello.
Well, now we have time for 3 or 4 questions. Is there any question from the audience?
Hi, this is Laura Bertolaccini. My question is for Jason on the basic side. So, we are very intrigued about these anti-NETs antibodies. And as it is work from your group, I'll take advantage and ask about them. How do you see them applied in the clinic, if you see them applied in the clinic? Because sometimes we look for antibodies that would help us monitoring. And as these antibodies may be directed to so many protein coagulation components, the NETs and whatever is stick to them, do you see them a good application maybe in the future as a monitoring antibody?
Yeah, thanks, Laura. I think that the assay we have right now in the research laboratory is not ready for the clinic at all. As you pointed out, it's a very complex substrate. And so I think it's a little more proof of principle in a way that we could, screen patients in high throughput. We are very interested in trying to, better understand what the specific antigens are within the nets. Further complicating things. I know we have data and Pierluigi has data about beta-2 glycoprotein the same way it can bind to negatively charged phospholipids, it also seems to like to bind to nets. So I think further, trying to separate anti-beta-2 reactivity from anti-net reactivity that may have spread there. We in prelim data are seeing some association with low complement levels. I wonder if anti-net antibodies may be better at forming immune complexes than what we see with anti-beta-2 antibodies, and so it may be, kind of unlocking a different, side of APS pathogenesis. So I think too early to say. We need to figure out antigens, make assays that are more reproducible by other groups, and then test in larger cohorts, all work that we hope to do if we can get funding.
Thank you. And now you mention it, and I cannot avoid asking for it. You mentioned complement. Have you analyzed or studied C3 or C4 deposition on nets?
Yeah, that's a story that's out there from other groups over the years. We do find, looking through the microscope, that you can see complement being deposited on nets, and there is an association between high levels of anti-net antibodies and low levels of complement, which I think is something we don't typically think about for anti-beta-2 antibodies. So that's part of where that hypothesis comes from. So we see the other interesting correlation is it seems some association between anti-net antibodies and endothelial cell activation, which is not entirely intuitive how that works, but I think sometimes when we find something unexpected, we'll be able to piece that together over time and have something pretty interesting. So look for more in 3 years on that topic, I hope.
Sorry. So maybe we found what the lupus anticoagulant is.
Yeah, maybe. I know we all owe a lot to lupus anticoagulant historically, but not to be controversial, but I still hope a day comes where we understand the autoantigens all specifically enough that we screen for those with a more modern type of assay. So.
There's one question over here, and I will ask just a small one to Danieli before we jump to the next question. You have shown us a really nice paper by the group of Maria Tectonido on the treatment of hydroxychloroquine. Do you think that using what we have learned from lupus and showing those type of papers, hydroxychloroquine is going or it will become the standard of care for our patients, or should be?
Well, I think that you started this very nicely, saying that we rheumatologists are biased regarding hydroxychloroquine, right? So back in Brazil, since we have very, very severe lupus patients, as I'm sure you do also here in Argentina, we say that hydroxychloroquine should be in the water tanks, in the roofs of the houses, right, for the patients. So honestly, I think that there are many papers, in the literature that they kind of mention the advantage of giving hydroxychloroquine. We have a lot of in vitro and in vivo animal studies showing, the potential reduction of thrombosis and also the connectivity, right, between the beta-2 GP1 and the endothelial. So I think that we kind of have basic research to suggest that hydroxychloroquine is good stuff. I think that this paper, they only had like 25 patients in each group. This is such a small study, right? And of course that our patients, it's not very easy to be able to understand this in such a small group, since we also have many other confounding effects. But I really trust, and I hope that the hibiscus trial, because this is our hope, right? We couldn't study the primary thromboprophylaxis effect of hydroxychloroquine in the APS action group, for example, due to funding. So I really hope that this bigger and very well-structured, multi-center, double-blind hibiscus will help us to define this better. But telling you the truth, because when people ask things in In the meetings, I always ask, do you want the scientific answer or do you want the practical answer, right? Because the patient is in front of you. And it's very hard to think only about the evidence once. So if you have a patient that is having rethrombosis, he's already on target, you increase the target, you give them statins, and they still have thrombosis. We are not talking about the majority, this is really minority, but why not giving hydroxychloroquine? So I think that in the end, us clinicians, we should balance pros and cons, and to be very wise for the decision, and also share with the patient the decision. You know, many times I tell people, you know, I don't know this answer, but let's discuss and see, you know, which strategy is best for you. I hope I answered your question.
Well, clopidogrel is a platelet inhibitor drug frequently used in patients with a history of cardiovascular disease. Is there any place for clopidogrel in the management of APS, either alone or associated with aspirin?
This is also another very interesting question, and I remember one time I have done a review for a study group in ACR, and actually it was about many of the old antiplatelet therapies that they are used in other situations but not used in APS. So I think that there is place, yes, for clopidogrel. We also know of people who have allergy to aspirin. But telling you the truth, I'm not sympathetic. I'm pretty sure that there are many hematologists here, and maybe it would be really great to also listen to their opinion. But of course that we are biased when you see bad stuff in your hands, right? So like, for example, I've seen, not so many, but I've seen vasculitis associated with clopidogrel. And I also think that young women, they tend to complain a lot because, you know, they get a lot of light hemorrhage, like they tend to get bluish in their skins. So this is not my first option, but I think that of course there is a place to clopidogrel, and also all those patients who undergone cardiac procedures and they need a dual antiplatelet therapy. So, you know, we need to expect at least the 6 months that they are on the dual antiplatelet therapy.
Well, we don't have more. Oh, another question, and this is the last because we don't have more time.
Hello, good morning. My question, I am Francesc Miró. My question is for Danieli, Professor Danieli. Is about in the future and on the treatment of oncology, as you mentioned, more immunocheckpoint inhibitor will be used. Then maybe in your opinion about we must be, or clinicians must be very careful about apparition of more autoimmune disease because regulance of tolerance will be lost, and especially on IPS.
So you were completely right. So I really love this topic, you know, of all autoimmune manifestations that are associated with the checkpoint inhibitors. I honestly think that we rheumatologists should be closer to the oncologists, and my opinion is that, so like for example, in that paper I presented, you see that the first 4 cases, the patients were treated for melanoma, and the last one for the lung cancer. So this just reflects that these drugs, each time more, they are more given for patients. And I think that we should be closer to the oncologists because these patients, they come late to us. Many times the oncologists, I understand their point because they are treating a very, very severe disease and a lethal disease, but they kind of send the patient to the rheumatology a little bit late. And in the beginning, they started to give prednisone for these people, and the patients did good. But in the end, they realized that the end point for their cancer survival was worse. So now they are concerned with this. And another thing that I need to say regarding the checkpoint inhibitors is that I remember one patient, and for me, this always comes to my mind. The guy had a very, like melanoma, very severe disease. He was treated with dual anti-PD-1 and PD-L1 therapy. And it really impressed me because he said, you know, it doesn't matter to me to be alive suffering this much, because the guy had very severe arthritis as a side effect of the checkpoint inhibitors therapy. So we are treating a patient. The patient is a whole person, and we definitely need to work together to improve our management.
Okay, thank you, Dr. Danieli. Thank you, Dr. Bernardo Pons-Estel, to be here. We close this session now. We are waiting for the closing the meeting in 5 minutes. And all the present, we invite you to come here to take the picture. Thank you very much.
Thank you, Jason.